All right, guys, welcome back again to another episode of Healthy Design. We'll talk a little bit more about pain today and chronic pain. Again, this is a big issue. It affects at least one in five. And if you're in pain, even just for a short period of time, it can affect a lot of things, affect mood, etc. So just imagine if you're in pain for an extended period of time. One of the concepts we kind of mentioned briefly, just kind of in passing last time, was DIMS and SIMS. This is a concept from the book, The Protectometer. And so, if you want more information, I would recommend getting that book. You can find it on Amazon, noigroup.com. I'm pretty sure they have it for sale there as well. But the DIM and SIM, so DIMS and SIMS, the DIM is danger in me. So it's credible things that signal danger, and it could also be things that aren't credible. And so that's why we have this ability to change it. And then the safety in me is the SIMS part of it, and that's things that are credible for safety. And so that can help turn that DIM into a SIM, and then hopefully take some stress, some threat away from the pain system, and then we don't experience pain, or at least we experience less pain. So this covers everything. So it's all your senses. So what you hear, see, smell, taste, touch. It's also the things you do. It's the places you go. It's the people in your life. It's what you think and believe. It's what's going on in your body. I think I'm missing one. But anyway, what you could do is, like, for each of those categories, list out things, either thoughts that you think are dangerous or what truly is dangerous, and then list out things that kind of are safety. So, you got, examples. You could be like, oh, well, it's just old age and I'm going to hurt and stuff. Well, is that actually true? Do we have to hurt just because we're in old age? And so maybe having a little bit more understanding of pain neuroscience can actually take that, oh, well, I understand what's going on. And so now it's not just this old age thing. So those things can make a difference. Also, like, kind of where you are and the people around. Like, if you're going to a doctor's office, that's going to be a little more threatening just naturally than going and doing something with your best friend. So try to keep those things in mind, and it's just a way to kind of reframe things a little bit, and so take that threat away. Actually, that's one of the biggest things, I believe. Our pain system's trying to detect danger and threat because it wants us to survive, and so it's going to do what's best for us to survive, plain and simple. And so what can we do to make it feel less threatened so it doesn't protect in that way? um, so the more on the treatment side, I'll kind of go through some of the basics, I guess, first, and then maybe share two examples from patients I've had over the years. So I do like the graded motor imagery approach. I was exposed to David Butler and Lorimer Mosley when I was still in PT school. So this was like 2000, 2001. And so that's definitely kind of who I followed this whole time. There are a lot of other people, a lot of other really good people that are researching pain, talking about pain, and have good information. And there should be a lot of overlap between what I'm saying and what they're saying, what Butler and Mosley are saying and what they're saying. Maybe not exactly the same, and it's probably a good idea to listen to different sources as well, because they're probably talking about the same thing or the same principle, but they're going to share things a little bit differently. And one of those ways may connect better with you. Which I guess this will take me down a little tangent, but that's one of the biggest things, I believe, for people to get better, is that they have to believe in it. If you don't believe in it, it's not going to do anything. We've talked a little bit on some of the other videos about, like, training, especially follow along with the workouts I'm doing. And I love training for sport and different things like that. And transfer of training is a big concept. So, like, what is the training you're doing actually going to carry over to the sport or activity that you're wanting it to? And the biggest thing that kind of determines that is if the athlete believes it's going to carry over. If they don't believe in the training, they're not going to give full effort into it. They're not going to get the benefits from it. Even if it is the best, most optimal training system ever, they still won't get the results. So that belief plays a huge part in things. So anyway, Graded motor imagery starts with left-right discrimination, and then more explicit motor imagery, mirror therapy, and then movement. As I said last time, movement is the biggest thing. We want to get people where they can move, but the trick is, can we get them where their brain thinks they can move and move safely, or where their pain system thinks they can move and move safely? So the left-right discrimination comes in because what they found with pain is that the brain can't really distinguish between left and right. Um, there's a part of the brain called the sensory homunculus that maps your body and the sensation side of things. There's also a motor homunculus too, which maps the movement side. And so the way your brain sees you, you're kind of funny looking because areas of your body that are sensitive are going to cover more area of your brain. So you got a large head, large lips and hands, fingers, small back, small little arms and legs, and big feet. Just because of those areas are more sensitive, so they take up more area of the brain. So that's how your brain sees you. It doesn't see you as the way you actually are. But when you have pain, that can get smudged or distorted. So like one of the examples from one of their books is like, you got right and left hand, but instead of seeing each finger clearly, like, a couple of the fingers or all of the fingers are smudged a little bit. And so then that can lead to some of that loss of left-right discrimination. So NOI Group has a app called Recognize, but you can do this other ways as well. But with that, it works on that left-right discrimination. And so I've used that with several patients. And what I like about it, is that you just see pictures and you can start at a very basic level and progress to where things are more advanced. And you can start with a low number of pictures and increase that. So there's different ways to progress. And, as your body adapts, you can do more. I like that side. But you have to determine whether, we'll just take hands in this case, whether it's a left hand or a right hand. And it'll time how long it takes you to answer that question, and also whether or not it's accurate. And so what they've shown is that sometimes this can work out different ways. So that's why I say sometimes. So sometimes if people, let's say they have right-handed pain, then their pain system may be so protective that they're going to see everything as a left hand to start with. But you're not truly trying to think about this when you do that app. You're just trying to answer as quickly as you can. And so the brain's going to be like, okay, it's a left hand. Oh, wait, no, it wasn't. It was a right hand. And so that's going to slow down that time. So you may see like this increased time period to answer things when it's that hand that hurts. And they answer really fast when it's that hand that doesn't hurt. Sometimes they're so overprotective that they see everything as just being that side because they're so focused on it. So, you may see the opposite result. So you have to have some knowledge and ways to kind of interpret things. It's not just this one size fits all. Which, I mean, when we're dealing with treating anybody, there's not a one size fits all approach. That's why I'm not too big on protocols. Because people are different, they're going to respond differently. I like having that kind of framework kind of in the background, but not something where it's specifically each little thing, because people are just different. So anyway, that's my little spiel there. And so once you start, by doing this, you start to, this is my word, I've trademarked it. It's, so nobody can use it, but I call it homuncular refreshment. So by touching somebody too, I think you can get some refreshment of that homunculus to where maybe now that area has been stimulated and now the brain's starting to get a better image of the body. So instead of that hand being smudged, maybe the fingers are starting to come into play. Because for me, when it comes to treatment, I definitely love manual therapy and think that can be very helpful for back pain and other things too. And a lot of times we will say that, oh, I'm working on this joint, doing joint mobilizations, blah blah blah, and I do think there's some truth in that. But I also, so like moving C6 on C7 to help increase cervical rotation or something, I do think that could be the case, but I also think sometimes just as soon as we touch somebody, that may be what made the difference for them, because it may have given some input to the brain and it changed things. So I've heard stories. I don't know if any of these are true, But I've heard stories of therapists that went to Australia to train with Maitland, and he like they were doing that joint mode on C6, C7 in this case, and he'd ask what they were treating, and they would get real specific or say, "I'm treating the joint, blah blah blah, this movement on this," and he would do the Gibbs NCIS, smack them upside, the back of the head, and then what are you treating? I'm treating everything underneath my finger. And I think that's important because I mean, there's skin there, there's nerves there, there's blood vessels there, there's fascia there, there's ligaments and tendons and muscle and bone. So I mean, everything's there. We can't be that certain exactly what it is we're treating. The good news is we don't have to. We can still get results. So keep that in mind. But if we can get that refreshment of the homunculus, if the brain can now see the body clearly, that in and of itself could help decrease the threat. So that could help decrease pain levels. And so that might be where we have to start. So this is the graded motor imagery is kind of a continuum. We're trying to get to movement. We just want to make sure we can get there and get there safely. And so you have to start somebody wherever they are on the continuum. It's not always, oh, you start at this. Because, maybe they're not having any issues with left-right discrimination. They're able to answer 100% correctly, and they're able to answer very, very quickly, even at the highest levels. Well, then we need to move them up. So next comes like explicit motor imagery. And so this could be where you're using visualization. Maybe you're just, there's other different things. And you can watch other people doing things too. So the good thing about visualization, athletes have been using this for years, golfers working on their, swing or their putts, basketball players and their free throws. When you're visualizing something, your brain doesn't always know whether it's really happening or you're just visualizing it and it's not happening. And so we talked a little bit last time about like there's a sequence that things have to fire for you to experience pain. In this case, you're still having that same sequence fire, but it's at a low level to where hopefully it's not hitting that threshold to experience pain. So it should be like if that level's here, it should be fine kind of at this level. And so now we're starting to get some of that, sequencing going on, but not to where it's actually creating that pain output. So that can be very important. That can be a way to kind of start transitioning into doing things that you want to do and making it not as scary to your pain system when you do get to doing those things. Sometimes too, like what I've had people do is if they like sports and say they got a right knee problem, well, watch a football game, American football in this case, or soccer, whichever. But pick somebody and kind of focus on their right leg and just really intently watch their right leg. And I mean, it's amazing. Sometimes that's too much for people. That'll even increase their pain, even though they're just sitting there watching a game. But for other people, if it's appropriate for them, they do that and they don't experience any issues, and it does help them move up that ladder, so to speak, to doing more things. The next part is mirror therapy, and in this case, again, there's still no movement actually occurring, at least at the beginning levels. But we'll take that right hand pain again. So what I would do with the mirror is have it to where it hides the right hand, but it sees the left hand. And then I'm looking at the mirror. What that's going to do is it's going to look like a right hand to my brain. And so I can move my left hand, but it's going to look like my right hand's moving. And so again, that may stimulate that motor homunculus, that sensory homunculus, may help to de-smudge things, get things where it's clear. And then I can progress from there to where I am moving that right hand behind the mirror, so I don't see my real right hand moving. I see that mirror image, and then eventually I'm just able to do things without the mirror. There are different case reports and case studies of using the mirror therapy for people that have had a limb amputated, and sometimes you get just miraculous, phantom pain's gone with just the very first time they do it. That does not always happen by any means, but it can happen, and I think that's something powerful and something to keep in mind. Not to necessarily expect those results, but to know that they are actually possible, at least for some. Then after that, you're up to moving, and that's what we really want. there's been some different, well, there's been several now trials, like randomized controlled trials looking at graded motor imagery and, chronic pain treatment. And there's a Resolve trial that's pretty sure it's been published. But one of the concepts to now is for Lorimer Mosley and some of the group that he's working with is fit for purpose. And this is kind of some of the sequence they go through to try to show your body that it is fit to do different things. And so, again, with all of this, it's about trying to figure out where that person is. So, where we need to treat them kind of along that continuum and get them to feel safe and that they can do different things. Um, Two patients, like where I've used this. So one was years ago. It was before graded motor imagery existed, as far as I know. So there was nothing about left-right discrimination, different things then. But I had a person come in. I'll try to keep it as vague as possible, not to give away any information. But I had a person come in. They'd been diagnosed with fibromyalgia, had like 8/10 pain pretty much everywhere. I remember, where they live, they had like 7 steps to get up to get into their house. And, I tried doing some different education, showing some different pictures of the nervous system kind of at a normal state, one that's at a sensitized state that's going to be more, more pain producing, so more pain as an output response. And then another one where it's sensitized, but you got a lot more inhibitory signals coming down to try to manage that pain or keep pain from being experienced and that from being the output. So I showed some of those pictures, talked about things, and they bought in. So that, again, that's one of the big things. They believe this would be helpful. And now we combine that education along with moving and finding ways they can move without increasing their pain. But one of the key things I think for that person in particular was, okay, I know you got 7 steps to get into your house. I want you to go up all 7 because I don't want you sleeping on your front lawn. But try to reframe it. So instead of, okay, I did all 7 steps and now my back hurts worse, can you do 1 step or 2 steps without your back hurting worse? If you can, then once you do all 7, focus on that. Oh, I did 1 step and my back didn't hurt, or it didn't increase, didn't hurt more. And then maybe it gets to 2 and then to 3 and then to 4, 5, 6, and then all 7 without the pain increasing. And so they're like, okay, I can do that. It's not about trying to lie and be like, oh, I did 7 steps, my back didn't hurt even though it does. No, if it truly doesn't increase in pain with that 1 or 2 steps, then focus on that and, kind of trying to put a positive spin on it, but again, not lying to ourselves. And this person did that and did everything else. And I mean, within a few weeks, their pain levels were down more to 2 to 4/10. So this is almost like 2 decades ago. So I'm not sure that I got them pain free, but going down to a 2 from an 8, the things you can do and the way you feel is going to be drastically different. So they were pleased and did much better. And that was more in an outpatient setting. Another patient I had, they were more in a home setting and severe back pain. The first time seeing this person, they could only do maybe a quarter of what you need to do to go from laying down in the bed to sitting up. So we couldn't even sit on the side of the bed this first visit. Couldn't hardly move in the bed without increased pain, different things too. So I did have the left-right discrimination, different things with graded motor imagery in this case. And so what we did, went through some of the education, trying to teach some of the pain neuroscience to let this know that, it's trying to protect, but maybe it's being a little overprotective right now, this pain system. And so started with some of that education. And then since this was back, we did the recognize out for back. So you have to tell if you're turning right or left or leaning right or left. So we started with that. And then again, I like to have some movement in there as best we can. But I don't care if it's related, that movement's related to the area that hurts or not. I just want there to be some movement that can be done that doesn't hurt, that's non-threatening. So in this case, for this person, they were laying like with their head on 2 pillows and they would just pump their ankles. And so, I mean, we could do that. It didn't increase pain, so at least we got some movement in. We would keep trying to add some movement as we could, and as long as they felt safe and it didn't make things worse. And we made the images harder with the Recognize app and different things too. I don't remember the exact time frame now, but definitely within 4 to 6 weeks, the person was getting out of bed. They were able to walk into their living room, kitchen, and come back. And I'm not saying that's going to be all that you want, but we were able to go a little bit further before having to transition them to an outpatient setting. But able to go up and down steps, get out of the house, and everything too, from not even being able to sit up on the side of the bed. To me, that was a huge improvement, and I'll take that. Again, I wouldn't want to just stop there, but that does have a tremendous positive impact on their quality of life now that they can move around in their house and get out of their house from time to time too. So that's a little bit about how I've treated people. Outpatient settings too, I would add in some of the hands-on treatment. That person in the home setting couldn't really do a lot of the hands-on treatment, so joint mobilizations, different things along those lines, because it just didn't have the equipment available. And especially early on, there was no way we were going to be able to get them out of the bed and then onto like a treatment table. That would have been impossible. So the good news, those things don't have to always be done, but I think they can be a very, very good, very positive adjunct to therapy too. So anyway, this is hopefully gives you some information that can be helpful. If you are experiencing pain and chronic pain, then trying to find a good practitioner, someone who will kind of look at things from a holistic standpoint too, because again, I mean, we talked a little bit last time, diet can have an impact. Other lifestyle factors can have an impact on this too, because they can be deemed a threat. And the more threats, the more dangers we have coming in, the more likely our pain system is to try to protect us by producing pain. And so we want to look at everything and see what we can do to address things. Again, one of my big beliefs in treatment is that there's all this load on the body. So if we can just take some of that away, then our body's pretty smart, kind of knows how to handle things, and it can handle things. But if we've got all this load on there, the reserves aren't there for the body to do what it needs to do. So if we can take some of that off and have those reserves there, it can make a big difference. And maybe it's not even directly addressing something. So like I said, with the pain side, maybe it is just changing diet some. Maybe that gives enough of a reserve. Now the body can respond better to some of the pain side. So I don't think we always have to be 100% right, but yet we can still get to the outcome that we want. But anyway, that's enough for today, guys. Hope you've enjoyed this. If you got questions, let me know. NOIgroup.com, they have a lot of good information too. You can probably get you started in different ways. And then on YouTube, you can find different lectures from Lorimer Moseley, David Butler, etc. I think they're entertaining, at least. David Butler, I mean this in the nicest way possible. He's a little bit crazy. I got to sit in on a class with him, or he came to America to teach mobilization of the nervous system, I believe it was, and I got to go to that, and he was hilarious. So it's entertaining as well, and you get good information. So look for those things on YouTube, and I'll talk to you guys next time. Bye.